I'd like to introduce again Dr. Jamie Kitt, who gave our wonderful ECG talk a couple of weeks ago, and he's back today to talk about symptomatic arrhythmias. Jamie is a cardiology registrar, an ALS educator, and a clinical fellow for the British Heart Foundation. Welcome, Jamie.
Thank you, Lily. So tonight I'm going to give a quick overview of external pacing and DC cardioversion of brady and tachyarrhythmias. As Lizzie mentioned, I'm a cardiologist within Oxford at present. Fairly old, long in the tooth one. I'd like to thank Rosemary, who's the centre manager at Registrar, who helped film the videos with me, which are up on the HED website, and Lizy or Aimee will share these during the talk or at the end, and also the Research Council for sharing algorithms. A brief review of what we're going to cover today. We're going to have a look at the bradycardia algorithm to start and talk through it. Then we're going to look at how external pacing is performed, because even people who are actually practicing now rarely do this in between their ALS, and even during their ALS, they may not be the person who actually gets to do this because you all rotate through different stations, so it's something that is poorly done. There'll be a few practical tips about what can go wrong, sort of a troubleshooting during external pacing. Then we'll look at the tachycardia algorithm and a video of cardioversion. Unfortunately, I'm in both of these and I couldn't cut myself out. And then we'll look at, again, practical tips on DC cardioversion and address any questions at the end.
Jamie, may I just interrupt one moment? We're having the audio issues that we had before again. Are you able to move a little closer?
I'm actually wearing a mic, but I can try using the, let me try plugging it back in. Is that any better?
Oh, that's much better. Yeah, thank you.
Okay, no problem at all. Thanks for letting me know. Do tell me if I'm speaking too fast too. So the bradycardia algorithm starts, as most ALS algorithms do, with ABCDE, which has been covered in the last talk and in other webinars. I won't focus on that. Main thing in assessing the patient is to ensure they've got adequate monitoring of their SATs, 3D ECG monitoring, and put a 12 ECG as soon as possible, because it's hard to make diagnosis on the rhythm from just a 3D or a rhythm strip to obtain IV access, and at the same time a venous gas, because that's invaluable, limiting your potassium, which often triggers rhythm problems. And then go on to assess for adverse features. Shock, which presents as having low blood pressure, being peripherally cold with a prolonged refill time. In the periphery, this would be 5 seconds or beyond 3 seconds centrally on the chest. They may give a history of not passing urine. Syncope, so either presenting with syncope or their ongoing syncope in front of you. They may have a chest pain with ECG changes on the 12-lead ECG, sagging or ST elevation, or T-wave inversion, or heart failure, i.e. the JVP. If it's visible, maybe up, there may be leg swelling and crackles in the chest. So the key thing is to assess these first. If these aren't present, you can sort of breathe a sigh of relief, take a bit of time, keep them on a monitor, of course, wherever you are within ED recess or on the ward. And then think, are these patients at high risk of actually running into a problem that may need pacing? So you need to look, are any of these 4 things? So do they have Mobitz 2AV block, i.e. are there 2 or 3 P waves to every QRS? We're not going to spend too much time looking at ECGs in detail because I did that in the last seminar, and that would all be available on the website. Do they have complete heart block? We will look at that ECG because I do want to show you that again. And particularly, is the QRS broad? Is there a higher risk of having a period of asystole, also known as ventricular standstill? And have they had a pause of more than 3 seconds, which is 12 small squares, on or rhythm strips from the ambulance or in the ED department or on your ECGs? If none of those are present, again, breathe, continue observation, and take a more detailed history and review the drug chart about factors that could be causing it, check the potassium problems, etc. But if they are present, you need to move across to the red box. And in most cases, people will give atropine at this point, giving 0.5 milligram or 500 microgram aliquots as a push, and you can repeat that 6 times. That's from 3 grams. practically speaking, in terms of complete heart block, it doesn't really work, but it does buy you time if they're in slow AF or in a mode it's 2. If you've given half a milligram and seen no response at all, giving more generally doesn't work. So at that point, you need to think about transcutaneous pacing or one of the other drugs, and the one that tends to be favoured at the moment, and that's probably the easiest to use, is isoprenaline. It's certainly the safest to use through a peripheral line. I'll talk a bit more about the practicalities of doing that later on. So just a quick reminder, if you did miss the ECG talk, when you see a bradycardia ECG, calculate the rate. The simplest way to do that in a slow ECG is look at the number of R waves and times it by 6.
Jamie, the line is still pretty poor.
Sorry, is that better?
No, I'm so sorry.
I'm just going to switch the computer around here. Is that better?
Say something.
Can you hear me now?
Yes, I think it's better.
Okay, let me just try moving to a...
Oh, that's much better.
Okay, so just to recap the rate, it's the number of R waves times 6. Then move on to look at the QRS. Is it less than 3 small squares, i.e. narrow, or is it broad? Because this is telling you if it's narrow that the problem's above the AV node, and the only real thing that's that slow above the AV node is slow AF. If it's broad, then you know it's coming below the AV node somewhere through the conduction system of the Purkinje bundle of hairs, and the broader it is, the more worried you need to be. Is the QRS regular or irregular? Irregular is always AF. And then you'll look to see if there are P waves to confirm that or not. And obviously the P waves associated with the QRS when we're looking at the different types of block. First degree, remember, being a long PR interval above 5 small squares or 200 milliseconds. Second degree block, as we talked about, 2 or 3 P waves is the one to worry about. The other one is Wenke back, where the P wave is there each time. Gradually the PR interval lengthens and then it drops. And then the next complex is associated with a short PR interval. And then third degree block we're going to look at on the next slide. So this is a reminder of what complete heart block looks like. So you will see a nice regular QRS. If you're not sure about that, and obviously it's hard on this screen because there's no small squares in the background, you'll map it out with a sheet of paper. You will see that when you move that along, you'll see the RR interval is fixed. When you do the same thing with the P waves, and you move along, you'll see these are not regular. They are just marching through at random, so that there is complete AV dissociation, which is the other term for complete heart block. So what I'm going to do now is show you a video of how external pacing is performed. I will pause it intermittently just to highlight a couple of points. It's about 6 minutes long. So I'm just going to start to play that now.
Hi, I've got this patient, Mike Walker. I've just put him onto the monitor into the either side. His pulse rate's very, very low, looking a bit like block.
Can I just check you can all hear the audio okay?
Yes, the audio is great on the video.
Perfect.
Hi, I've got this patient, Mike Walker. I've just put him onto the monitor into the either side. His pulse rate's very, very low, looking a bit like block, and he's compromised in his blood pressure as well.
Yeah, I think very good. Thanks for calling me. Mr. Walker, my name's Dr. Jones. How are you feeling at the moment, sir? Is he okay? Have you been feeling dizzy just today or for a couple of weeks? A couple of days. Have you had any blackouts? And that's what caused you to come to hospital, was it? Right. And what happened with that blackout? Okay, fine. That sounds highly likely that it's related to your heart rhythm. So bear with me, sir. I'm going to take some more history from you when you're a bit more stable. Just going to focus now on trying to sort out your low heart rate and blood pressure. So I'll be talking to my colleague. Okay, so airways patent. Yeah. Rest rate is a little high at 25. Yeah. Sats are low. So let's start some oxygen. Yeah. Have you ever smoked, sir? Okay, so let's start oxygen target 94 to 98%. Increasing oxygenation.
I'm just going to pause it there to say you do usually have the time to take a focus history, particularly looking at drugs that could be causing this rhythm, any notable past medical history, and obviously then you need to focus on are the adverse features that we looked at present. Remember, if the patient is compos mentis, to just let them know what's going on. And I will talk about the COVID-19 modifications for this at the end.
Okay, C, right, that's a very low heart rate, as you say. It looks rather suspicious for AV block. Let's see which degree it is. Okay, so here we have P waves marching through. They're not associated with QRS. It was very slow ventricular escape rhythm at 19, so it's not surprising the blood pressure is also. So we've got complete heart block and the blood pressure is low. So I think here we really start external pacing. So you're in a rhythm here called complete heart block, and what that means is essentially the top chambers and the bottom chambers of your heart aren't talking to each other, and as a result of that, there's a little sort of survival mechanism in the bottom chambers where the heart rate goes at a slow rate, but it's not enough to prevent you blacking out and to keep your blood pressure where you need it. So what we're going to do is support that now artificially by giving you a little bit of electricity through the chest to bring the heart rate and blood pressure up. Is that okay with you? Because the electricity can be a bit unpleasant, we're going to make sure you're sedated to remove that sensation. So I'll be asking one of my colleagues to come and give you some medication through this line to do so. Is that all right?
Just going to touch the defib here.
And the pads. While you're doing that, I'll just complete the ABCDE. We'll just get a blood glucose, and if you could just come up with the pupils. I've just had to look through this patient's GP notes, and there are no medications that slow him down, and the gas has come back, and the potassium is normal. There's nothing obvious, reversible. Okay, we have the 3D monitoring attached. That is vital in the case of pacing, because the pads cannot pace and monitor at the same time. So if you only apply the pads, you will not be able to use the pacing function on your defibrillator. Our anaesthetist has arrived and has performed safe sedation. I would not perform sedation on my own in a scenario like this where the patient is very unstable and may need airway support. So always seek to support an intensivist or anaesthetist who can support the airway.
Again, in the current climate, this may not always be possible given our intensivists and anaesthetists are really busy, and particularly if not in a tertiary centre. I will talk a little bit about how you could do this in the current pandemic, in a crisis, if need be, in a moment. Apologies. I'm just getting back to that part of the video.
So we're set to demand mode. We are at 70 pulses per minute and 160 megamps at start. So with this, we can leave the oxygen on.
Okay, anaesthetist, you have your patient sedated. There you are. Let's start pacing at rate. Excellent. Starting to see the pacing spikes appear there and also on our other monitoring. Okay, at the moment we're pacing at a very high amplitude, which would be unpleasant even with sedation, so I think we should turn that down. And what we're looking for here is the point at which we lose our QRS after the pacing spike. We do this slowly in 5 milliamp increments or decrements in this case.
Still pacing.
Still pacing. The normal range in which you'd expect electrical capture, depending on the size of your patient, between 80 and 100 milliamps. If it's a very large patient, you may have to go up higher, which is why this particular Philips machine starts at 170 and you go down. In your trust, you should familiarize yourself with your defibrillator. For example, life packs start low and you have to increment until you get electrical capture. Let's see. We've still got capture. There, it looks as though we may have lost it. That's lovely. We're saying lost on 1 beat there. So let's go back up.
Lost there, so it's by 10, so 85.
Have electrical capture. Can you confirm mechanical capture with the pulse?
Yep, I have a pulse.
Okay. Let's repeat our ABCD assessment now that we've got an adequate heart rhythm. We're just seeing a couple of ectopics there, I believe. Otherwise, we are having capture. So, airway, we're sedated, the anaesthetist is happy. Respirators come down, and the SATs are adequate on our oxygenation, which is 7 meters. C, we've got a heart rate of 70 to 80. Can we just do a DCG because we're seeing some pacing spikes, but I think we're seeing ectopics. I want to confirm that. Otherwise, we may need to adjust our energy on the pacing. Okay, so we do have pacing spike followed by QRS. Good. And we've confirmed mechanical capture. Our blood pressure's come up, which is good. If it hadn't come up, you obviously consider sepsis and hypovolemia. The patient's in heart failure, you can accept a lower blood pressure than normal, because the most likely cause of this low blood pressure has been complete heart block. Right. D, pupils are okay. Blood glucose. We removed the gas earlier. There were no electrolyte anomalies. There was nothing in his drug history that could be confounding. So we now need to move to a definitive plan. So what I will do is, while you and the anaesthetist continue, speak to our cardiologists about moving into the cath labs for a temporary or permanent pacing system. We're now going to talk through the Recess Council UK guidance.
So we've already looked through that guidance, but if you do want to watch that full video and a recap of the guidance again, that will be made available at the end in 5 days' time on the webinar or our website. So a few tips really to talk through about external pacing, and the key there, and you hear me mention it, is that make sure you've got your 3 leads monitoring attached as well as your pads. And that's the commonest reason in a stressful situation that people find put the pads on and they can't pace. It's because they haven't put the 3D ECG monitoring from the defibrillator, not from the bedside monitor. I talked briefly there about sedation. In an ideal world, when we're not in a coronavirus outbreak, you will have someone else there who's competent to sign off to do it. If there is a scenario where you can't do this, then a sort of fairly safe rule of diluting 10 milligrams of midazolam in 10 mils of saline, so you've got a 1 milligram per mil solution, and then give that 1 milligram at a time. And generally for a sort of 70 kilogram man, depending on how much alcohol they drink and their kidney function, 4 or 5 milligrams would be enough for them to be safely sedated for pacing. And you give it in 1 milligram aliquots. And if you're really, cautious, you can always make up for the Mazanil, the reversal agent, at the same time. Do be familiar with your own stress defibrillator. So when you do start back to practice, you saw there that was the Philips, which is set to start pacing at a high amplitude. And by amplitude, I mean the energy given to start pacing. And the higher the amplitude, the more uncomfortable it is for the patient. LifePak, as I mentioned, on the other hand, do not start high, they start low, and you have to increment until you get electrical capture. And those 2 terms I mentioned, electrical capture is the minimum electrical energy required to depolarize the heart muscle. And although you may see spikes, that may not be actually causing the whole heart to contract. So you always have to check when you see the pacing spikes that you also have a pulse that matches that rate. And that's called mechanical capture, when you feel the pulse. We talked briefly in the recess guidelines about isoprenaline, and as you may have seen on there, they recommend starting at 5 micrograms per minute. The BNF advice is very good on this actually, and that is to start at 1 to 10 micrograms a minute by an IV infusion. So remember, this is an infusion, not a bolus, and that's absolutely key in infusion. So you take 2 milligram ampule, it comes as an ampule, the nurses will make that up in 250 mils of glucose, and then start running that. And the BNF has a nice little table for the rate at which that's run, as to whether you're starting at 1 microgram, 2 or 3, and you gradually increase it until you get the rate. It's a very good measure in all forms of block at holding the heart rhythm at a level that's acceptable to maintain a good blood pressure, particularly if you've got concerns about coronavirus and you want everyone to be getting donned, and particularly if your cardiologists aren't keen to put a pacing system in, you can buy a day or 2. This is what a LifePak looks like. There's a 15, a 20 and a 25, but they all have the same buttons on. This is the pacing function, so you have to fit the pacer once you've attached your 3D ECG monitoring and the pads. The rate is set automatically at 60. You can increase or decrease it, but 60 will be adequate. And again, then you need to gradually increase the current up until you get capture. So we're going to move on now and talk about tachyarrhythmias. And again, if you missed the ECG seminar, I think the key slide to take away from that was the simple ECG assessment, largely in line with what ALS tell you. So is that fast heart rhythm regular or irregular? If it's irregular, it's always AF. That's nice and easy. If it's regular, then is it a narrow or broad QRS? If it's a narrow QRS, then the differentials, it's labeled as an SVT, but we like to try and think we can differentiate a bit more as cardiologists, but it doesn't really matter too much for these circumstances. If they're unstable, they all get cardioverted. But it could be a flutter, an AVNRT, an AVRT, which is an AV reentrant tachycardia, i.e. Wolff-Parkinson White, or it may just be a really fast sinus tachycardia and you can't see the P waves. If it's a broad complex tachycardia, there's only 3 things it can be. It's VT, and as I said in my other talk, if in doubt, treat it as VT. It could be SVT with pre-existing bundle branch block, and that's also termed interchangeably SVT with aberrancy, just to confuse everyone that's not a cardiologist. And SVT with an accessory pathway is the other thing, and that classically is the Wolff-Parkinson White. And I showed some good ECGs of what that looks like in the last talk, if you do want to go back and look at that. So the next part is going to be another video, and this is going to be showing how you perform external cardioversion. I think I play myself rather than Dr. Jones from Aqua in this one.
This is my ward who's just come in. He's got chest pain and put some monitoring on, and he has got a tachycardia of 213 and quite a low blood pressure on as well. And he's, as I say, he's got chest pain and is feeling quite unwell.
Thanks, Rosie. Thanks for calling me. Mr. Jones, my name's Dr. Kitt. Nice to meet you. I understand you're not feeling very well at the moment, and you've got some tightness in your chest. Is that correct? Have you ever had that before, or has it just been since the heart's been racing? Okay. Do you feel lightheaded at the moment? And do you feel out of breath at all? Okay. I'm just going to talk to my colleague while we do a quick assessment, so bear with me talking over you. So airways painted, please.
Yeah.
Respirator is 20. Sats are lower, 83%. Have you ever smoked, sir? Okay, so let's target options under 94 to 98. Start with hyperlow titrators. Okay, whilst the oxygen levels are coming up, we can also do arterial blood gas here to check for electrolytes.
Yeah, okay, I can get that.
And whilst that's running, we can move on to C. So as you said, the heart rate is 211. It appears irregular on onset, although you should never rely on the onset. So let's do a 12-minute ECG. Okay, so let's have a closer look at that. Very fast. So the rhythm is narrow complex.
So it takes a lot of practice to get an instant diagnosis, but that is irregular, and the RR varies. If you're not sure, go back to the simple method we talked about in the other seminar, which is get a sheet of paper, mark an RR interval, maybe 3, and then start to move along. And if you did that here, you'll see that they no longer line up. It's irregular, it's AF.
Yeah, okay, so that's atrial fibrillation. Blood pressure, as you say, is very low at 60/34. So I think we should cardiovert. Whilst I just get underneath system sedation, we'll finish the ABCD approach. So, hands are slightly cool. CRT is 3 seconds. You mind checking pupils for me, and then blood glucose. And the patient is A on the scale. Okay.
Pupils are reacting, and I've done a blood glucose, and it's 5.6.
Okay, Mr. Jones, you're in an irregular heart rhythm, which is fairly common, and there's various things which can trigger this, and we'll talk about that subsequently. But I think the focus now, because you're feeling lightheaded and you've got chest pain and a low blood pressure, is to try and get you back into your normal heart rhythm. For us to do that, we're going to give a little bit of an electric shock in a controlled manner whilst you're sedated, so it's not unpleasant for you. So my colleague now is just going to put some ECG monitoring onto your chest and some pads, which will pass the electricity through. And my other colleague, who's an anaesthetist, will give you some medication through the line in your arm, which will make you feel sleepy. So in an ideal situation here, they should be in ED recess on the monitor. If you don't have that facility, then you should be in an HDU environment. Theatres or intensive care. Okay. Right, Rosie. Would you mind turning on the defibrillator, please?
Yeah. Turn on.
Okay, so would you mind synchronising?
White dots are on.
Okay. Check the patient is safely sedated. Mr. Jones? Okay. Anaesthetist, are you happy? Okay. Right, Rosie, so we select our first energy. Let's start at 150 joules. Okay, and you can charge.
Okay, I'm just going to raise the oxygen. It's at 750, so I'm charging at 150. Everybody stand clear. Okay, that's charge. Shocking at 150, stand clear.
Okay, let's see what part we have. Okay, we've not Bristol science rhythm here, so let's ensure we're still synchronized to the other way. 750.
Still synchronized, yeah.
So we are. Okay, let's escalate to 200 joules. Okay, and again, I'm going to leave you in charge.
Okay, so oxygen's away, we're set at 200, charging at 200. Now let's charge at 200, shocking, stand clear.
That looks more promising. Let's do it now. QA, QRS, rate is confirm that we're in sinus rhythm with 12 ECG, and then we'll rerun through the ABCD approach. So the patient's just been sedated, so it's unlikely they're being talked to, so you check the anaesthesis if they happen in the airway. Oxygenation is good, and respiratory rate has come down. Confirmed we're in sinus rhythm at lower than 79, and repeat that blood pressure. The blood pressure will normally come back up after you've stopped sinus rhythm. It hasn't even been assessed as a challenge. Subsequently, we can sure there's no evidence of sepsis or hypovolemia that's contributing to that. D, we assess pupils. Blood glucose and again likely to change. GCS1 to get back to sedation. We're now just this patient in a recess environment. Until the patient was awake with GCS of 15 to 15, we would either refer to the medics or cardiology depending on local protocols. So we're now going to talk through the algorithm for random tachycardia in a little more detail. This is the Rhesus Council UK guidance from 2015. And we're just going to base it around the patient who just saw Mr. Jones. So when you first get introduced to this patient, assess them using the ABCD approach, look at the oxygen levels, and if they're hypoxic, as this patient wants supplement oxygen, the patient is able to give you a brief history. It's useful to clarify if they have COPD, just in order to target your oxygen saturations appropriately. You would obviously then go on to monitor the ECG and blood pressure and look at the 12 ECG to ensure you've got accurate diagnosis of the heart rhythm. In this case, the patient had IV access, but otherwise you'd obtain IV access, and a gas to look for electrolytes, pH, lactating glucose, and other additional useful information it provides. The key thing then is to assess whether the patient has adverse features. In this gentleman's case, he had chest pain and some subtle sagging in his ECG suggesting myocardial ischemia. He also had shock, his blood pressure was low and he was peripherally shut down. The other features that may be present, syncope or heart failure. So, given this patient failed 2 of the NCM criteria, we found the Rhesus Cancer guidelines here around the traditional NICE guidelines for management of AF, which we'll talk about subsequently. So, we proceeded to perform a synchronized DC shock. In this case, we should seek the support of our intensivist or anaesthetist for what is available to you to perform self-sedation to work to this.
And once again, as I mentioned earlier, this video is not made for the coronavirus pandemic specifically, and it may be you need to follow the guidelines and that sort of cheat in a real emergency situation if you can't get anyone who's competent at sedation and airway management to do gentle conscious sedation, as I outlined previously.
The first shock is performed at 150 joules, passed to Rosie to talk through the attachment of the defibrillator pads, leads, and defibrillation process.
We
So red on the right, yellow on the left, and
The video audio is very unclear, Jamie,
in the upper sternum below the clavicle.
just now.
There are outcomes on the page that assist you in placing the pads. Should you get them going the wrong way, there is some risk that the ECG will be upside down. If this position is not successful, or for some patients you may need to avoid the right clavicle area, for example, those patients who have implanted medical degrees. Therefore, the position can be used. For this, one pad is placed over the left of the pads, and the other is placed on the back behind the heart.
You might have to narrate, it's quite buzzy.
I'm just getting some feedback that the video quality, the sound quality is pretty much gone. So I'm just going to narrate manually now, just to illustrate some key points. What Rosie was saying there is attaching red for right, yellow for left, green for spleen, and the pads can either go, as she showed in the top right, just below the right clavicle, and then below the left nipple, or if they've got a pacemaker or defibrillator, then AP is often better, or if they're a very large patient, AP often works better as well. What she's now going on to show, and I'm just going to turn the sound down here and narrate in person, is the defibrillation function on a Philips. And again, LifePak is very similar. The key thing is that you have synchronized before you do any shocking, and that's these little white dots just here. Seems like the video has crashed, and that's probably why the sound quality has gone. It started again, and those little white dots, they just come up circles to highlight. And that's what synchronization looks like. Philips always say synced. LifePak devices, for some reason, the sync goes off after you delivered a shock. So it's really important that you push that sync button again. And I've seen even consultant cardiologists forget that. And it's quite embarrassing if you put your patient into VF on an elective cardioversion list. So do check that those little dots are appearing before you push a shock button. That's the key learning point. Okay, so a couple of tips about cardioversion. Talked about sedation. So previously we said 10 milligrams in 10 mils. The other option is that you use a combination of drugs. Obviously, you need to be familiar with these. So I would say if you're not familiar at all, just stick to the one. But if you do have a bit of experience, you've got an ED, SPR or consultant with you who can do it, they'll often use midazolam, 5 milligrams and 50 to 100 mics of fentanyl, just because it's a little bit more unpleasant to have the cardioversion than the external pacing. So it's a little bit of extra sedation. Cardioversion is not aerosol generating. Remember to synchronize to the R wave, as I just said, and energy selection. So flutter requires a lower energy, so you can start at 100 joules. You only want to give the patient one shock, so there's no point trying to be a hero and go even lower. I know it often will work, but go at 100 and it'll work. In AF, we generally start at 150 and then escalate to 200 as we did in this video, and beyond that up to 360. If beyond this you're going to higher energies, you often want to move the pads to avoid giving skin burns. And as you'll see on the recess tachycardia algorithm, at this point you give the amiodarone. You not give it as a bolus because it really crashes blood pressure. So you need to give it 20 minutes, I would say, it's the fastest, in 250 mils of 5% dextrose. If they have come into AF, remember, this may be their first episode and you need to have that discussion based on their CHADS2 VAS score, which I discussed last talk about anticoagulation. I'm going to briefly talk about the other part of the rhythm, the tachycardia algorithm, which is narrow complex tachycardias, which are regular, which you give adenosine, and we did touch on this last time, but in case you missed it. It's a very safe drug with no long-lasting effect, a half-life of 12 seconds. It's often underdosed, which is why rhythms are not terminated. The ALS algorithm says 6, 12, 12, which is fair enough. Generally 6 and 12, if it's slowed the rhythm but not completely worked, you need to go up higher, so 18 and 24. I agree, once you get to 24, you may start to feel uncomfortable. Do call us as cardiologists. So what will it do to a narrow complex tachycardia? If the rhythm involves the AV node, it will terminate it. I've seen 2 cases in 12 years of being a cardiology reg, or a stitch line reg, that's make me very old, where it doesn't, and that's where the AV node is very, very, very fast. In those particular cases, you need to give another drug that slows down the AV node's conduction, and either verapamil or an IV beta blocker like metoprolol would be the case there. If the rhythm is coming above the AV node, i.e. atrial flutter or IF, it will slow the rhythm down because it's slowing the conduction down to the AV node, but it will not terminate it. It's very helpful in showing you what the rhythm is. So, for example, this next ECG has the lovely classical sawtooth pattern for me, and I know instantly that's flutter. Everyone who's not used to looking at ECGs may not. So you may think, what is this? It's certainly a narrow complex tachycardia. QRS is a narrow, it's fast, it's regular. Adenosine is a very reasonable next step, and this is the same patient after 12 milligrams of adenosine, and you see that classical sawtooth pattern. After about 10 to 12 seconds, you'll see the rhythm return back to that, but you've made the diagnosis. Remember, if you are going to give adenosine, to put the pads on just in case. You do need to pace. Very rarely the AV node takes a little bit longer. People have got a very long refractory period, so you want to have that option. Remember to start printing the rhythm strip before you give the medication so that you can show anyone, like a cardiologist, if it is flutter, that you actually proved it so that they can go on and do an ablation down the line if needs be. And remember to warn the patient that they will get breathlessness and tight chestedness, and it wears off quickly. So the COVID-19 specific modifications to pacing and cardioversion are that, and as most trusts are now saying, actually any contact with the patient, you should be wearing a level 1 PPE, but certainly for this, a minimum level 1 PPE. If there's suspected or confirmed cases, for our trust in Oxford, it's for all patients. The oxygen sats, if you listen to the respiratory seminar yesterday, is slightly different. So it's 92 to 96% rather than 94 to 98. And again, it's slightly lower rather than 88 to 92. There's a bit more leeway for COPD patients as well. When you're doing these cardioversions or pacing, do avoid starting an aerosol generating procedure. I don't put on CPAP or high flow nasal oxygen, such as Airvo, and don't bag and mask them because that is aerosol generating. If you think the patient, is really heading towards that, then you perhaps want to ask the other team members to start donning level 2 PPE so that they're ready in advance should that switch to bag and mask, which is not advised, but odds and need for intubation come up. And the last slide, and it's been a long evening for you, is just a brief slide about pacemakers and ICDs. We are going to send a link around to a really good video. I apologize for the slightly cheesy delivery of the video. It's even worse than mine. It's delivered by an American NYU resident. It is very good and it's 5 minutes long. And it shows you actually how to apply the magnet. But essentially, on almost all resus trolleys in ED, there'll be a little blue magnet. You put that over a pacemaker box. It switches a little reed switch within the pacemaker to the pre-programmed manufacturer settings. And those vary depending on who the manufacturer of that pacemaker is, but it'll always be a rate around 90. So the 2 reasons you would do this is if someone's come in with a blackout, it's very hard to get hold of a cardiac physiologist to check the pacemaker, given the current climate. You put the magnet on, you start to see pacing, you'll tell the patient their heart's going to speed up, you print the ECG or a rhythm strip, you show that it's pacing and it's fine, they can go home. Also, if they're coming in with a tachycardia, a tachyarrhythmia, and it appears to be a pacing spike before every one, if you do the same principle of putting the magnet over the box, it'll put the pacemaker back into a different mode and it should deactivate that pacemaker-mediated tachycardia. So it's got 2 benefits. It'll only work for that while you leave the magnet on the chest. When you remove the magnet, it'll go back. Generally, if you leave the magnet on there for 10 to 20 seconds, it will completely terminate the pacemaker-mediated tachycardia, but you need to use drugs like beta blockers as well. In the case of an ICD, what it does is deactivate the therapies. Obviously, the only situation you want to be doing that in are if you've decided someone's for DNA CPR because of COVID-19, they've got an ICD and you can't get it deactivated, you do not want that device inappropriately shocking them. That's highly unpleasant. So you would leave the magnet over the box if you've made them DNA CPR until a cardiac physiologist can get there and definitively turn it off. The other time is an ED if someone's coming in with a broad complex tachycardia and they're seemingly being shocked all the time. These devices have 2 zones programmed. There's a slightly slower zone, it's called slow VT zone, generally around between 140 and 160, but that may be lower if they're a much older patient. At that point, the device does something called anti-tachy pacing. What it's doing is just trying to pace in between the rhythm and terminate it. And that feels a bit like a twitching to the patient and is less unpleasant. And then it has a second zone program. There's a fast VT or VF, which is usually 210 minus your age, at which point the device shocks them, which it really knocks the patients to the floor. And obviously, if they're getting that shock, which is highly unpleasant, you do want to deactivate that if it's inappropriate. And so you put the magnet on them. The video again shows you how to do that in practice. That's the links there to that video, which will come around. Time for questions.
Thank you very much for that really lovely talk, Jamie. And despite the audio problems, I think everyone's really taken a lot home from that. So thank you.
Yeah,
Just a couple of,
it worked perfectly in the practice.
just a couple of questions. If somebody is in hypotension because of arrhythmia, in the context of tachyarrhythmia, would you give fluids?
That's a good question. So generally, as you saw in our videos, the blood pressure will come up once you restore sinus rhythm because the heart's become more efficient. It's not beating at 150 to 200 a minute. So the atria can fill properly, the ventricles can fill properly, pump out all of that blood into the blood vessels and give you a good blood pressure. If, despite the fact you've restored a normal rhythm, it hasn't come up, then give a 250 ml bolus. If you know how to do focused ultrasound or you've got someone around who's with you, they can always assess the fluid status of the patient by scanning their IVC. And if that isn't available, good old-fashioned, do you feel thirsty, look for the JVP, test skin turgor, but by all means giving a fluid bolus if they remain hypotensive afterwards.
Thanks. And when we're doing cardioversion, if we've given the 3 shocks and had no positive effect, what should we do then?
So that's where the algorithm suggests the use of amiodarone, and it says to give over 10 to 20 minutes. as I said, it will drop the blood pressure, so we tend to give it over the 20. And so what we tend to do is start the amiodarone infusion and then escalate the energies up above. So some of the defibrillators can go up above 360, some won't. If you've been currently using the pads in the position below the right collarbone and below the left nipple, then I would switch the pads across to AP. Often that works because you get a better transmission of the energy, and I would go at 360. And if not, wait a few minutes for that amiodarone to start taking effect. Again, move the pads to AP, have the energy up to its maximum, and again, you can try it to another 3 shocks. If after that you're not working, then you really need to be contacting an expert.
Thank you very much. And thank you very much, Jamie, for joining us this evening.
Thanks, Lizy.
And thank you to all our attendees for joining us. Just so you know, I know there's been a lot of links given in the talks today, and they will be put into the bit.ly/COVID-returners document, and all of those links will be available